Hello dear students, today we are going to discuss a clinical vignette on Hydatidiform mole. A 35-year-old Gravida 1 Para 0 female presents to the emergency department at 11 weeks of gestation, complaining of severe intractable nausea and vomiting, that is hyperemesis gravidarum, along with a recent onset of dark brown vaginal spotting. She reports feeling excessively fatigued and has noticed some mild tremors and heat intolerance over the last 2 weeks. On physical examination, her blood pressure is increased, her heart rate is also increased, and uterine fundus is palpable midway between the pubic symphysis and umbilicus, which is significantly larger than the expected for an 11-week gestation. Fetal heart tones cannot be auscultated with handheld Doppler, and laboratory studies reveals quantitative beta HCG very high level, reaching up to 285,000 milli-international unit per ml. Hemoglobin slightly reduced, that is 10.8 gram per deciliter. TSH levels are decreased and free T4 levels are increased. So from this clinical history, examination and laboratory findings, what we have that a 35-year-old female presents early in pregnancy around 11 weeks with nausea vomiting that are intractable, that is she is having hyperemesis gravidarum along with recent vaginal spotting, and features include the fatigue, tremors, and heat intolerance. So the symptoms of fatigue, tremor, heat intolerance favors the and the lab features favors the hyperthyroidism, and these symptoms are due to hyperthyroidism. Hyperemesis gravidarum is due to very high levels of beta HCG, which acts on the vomiting center in the brain and increase the propensity of nausea and vomiting. She is also having the preeclampsia early in the pregnancy, and this is also due to the very high levels of the beta HCG, because this beta HCG increase the levels of soluble folate 1, and this binds with the freely available vascular endothelial growth factors and placental growth factors, and this causes reduction of these vascular endothelial growth factor and placental growth factors, which causes endothelial dysfunction, and it leads to pregnancy induced hypertension or preeclampsia. So this is also due to the very high levels of beta HCG, and the uterine fundus is also larger in size, reaching between the pubic symphysis and umbilicus, uh, which is significantly larger than the expected for an 11-week gestation. This also suggests the presence of something in the uterus, either the blood in the collection of the blood, either collection of the trophoblastic tissue, either other material in the uterus which causes expansion of the uterine size more than the expected. And the most important thing is the absence of the fetal heart tones, that is, there is no sign of fetal viability, and such high beta HCG on labs is always favors the trophoblastic tissue growth, tropho trophoblastic tissue which releasing the beta HCG, and this is the case of H mole. Very high levels of beta HCG releases from the syncytial trophoblast. So what is H mole? H mole is nothing but the excessive growth of trophoblastic tissue forming the fluid-filled trophoblastic tissue growth, and it appears as the grape-like tissue in the uterine cavity, and this consists of the trophoblastic tissue only, and it releases the high amount of beta HCG, and hydropic swelling of the tissue causes the increased size of the uterine cavity, and H mole are of two types, either the complete H mole or incomplete or partial H mole. Complete H mole, that is only the uh, trophoblastic tissue is there and no fetus tissue is available. In partial mole, both trophoblastic as well as the fetal tissue will be there. Let's see further. A transvaginal pelvic ultrasound is performed to evaluate the pregnancy, and a representative transverse view of the uterus is shown below. Here we can see the presence of the multiple small cystic cavities, these small cystic cavities in the uterine tissue, and there is no fetus tissue available. So this is known as snow storm appearance, and this is the classic feature for the complete H mole. In cases of partial mole, you will see some fetal tissue along with the cystic space. So this is the case of complete H mole. Let's discuss further. Question number 1. The ultrasound image above displays a characteristic snowstorm appearance. What is the most likely karyotype of the tissue filling this patient's uterus? The karyotype of the complete H mole is usually 46XX and is of and karyotype of partial mole is 46 sorry is 69XXY or 69XXX or 69XYY. So complete mole is formed when a empty ovum in which there is no maternal genome available fertilized with the 23X male sperm, and this leads to the formation of 23X nucleus, which then duplicates its genome and forms the 46XX genetic material. And this genetic material comes solely from the male gamete, so it only forms the trophoblastic tissue with no fetal tissue. So it will form the complete H mole. However, in cases of partial mole, the normal ovum, which contains 23 X or Y chromosome fertilized with the two sperms, and this leads to the formation of genetic material of 69 XXY, 69 XXX and 69 XYY, and it leads to the formation of partial mole which contains both trophoblastic tissue plus fetal material. Because there is some maternal genetic material is present which helps in the formation of fetal tissues, and this partial mole forms. Partial mole usually comes to notice later as compared to the complete mole, and uterine size also not that much increased, and they usually presents with the as missed abortion. So from the options, option A, this is partial mole. Option B, 46XX containing both maternal and paternal. No, because it contains only the paternal chromosomes. So option C is correct. Option D, 45X0. This is the Turner syndrome. Option E, 47XX with trisomy of chromosome 21. This is Down syndrome. Now come to the next question. Which of the following best explain this patient's symptoms of heat intolerance, tremors and suppressed TSH? These symptoms of hyperthyroidism is due to very high levels of HCG, that is human chorionic gonadotropin, which releases from the trophoblastic tissue, and it has two subunits, alpha and beta. Its beta subunit is very specific. However, the alpha subunits have molecular similarity with the uh, hormone like TSH, FSH and LH. So it gets bind with the receptors of these molecules also, and it leads to the TSH like activity, which causes the increased thyroid hormone synthesis, and this suppresses the TSH release from the pituitary, and this causes the hyperthyroidism like features. So the cross reactivity of the massively elevated beta HCG alpha subunit with TSH receptor is the correct option. Option B is the correct option. Next question, the patient's blood pressure is increased, that is 155 by 95 millimeters of mercury. In the context of her current condition, this finding most likely represent which of the following? As we have already discussed that very high levels of beta HCG causes increased concentration of soluble FLT1, and this binds with the freely available VEGF and placental growth factors, leads to reduced concentration of these two molecules which are helpful in the angiogenesis, and it leads to disturbed angiogenesis and endothelial dysfunction. And this is the most important mechanism of pathogenesis of pregnancy induced hypertension or preeclampsia. So the option which is correct is the presence of preeclampsia occurring atypically before 20 weeks of gestation. Option C is the correct option. Now come to the next question. If a gross pathological specimen of this uterine tissue were examined following the surgical evacuation, which of the following findings would be most prominent? The treatment of the complete H mole or partial H mole includes the suction, evacuation, along with oxytocin or methergin to reduce the bleeding from the uterus, and followed by the serial monitoring of the beta HCG levels. So after the suction evacuation in complete mole, see the we will grossly see the grape-like clusters, grape-like clusters or vesicles, and in many cases they are also come out spontaneously out of the uterus, and so in complete H mole we will see the hydropic hydropically swelled uh, vesicles, and within absence of any fetal tissue. If there is any fetal tissue, then it will be the partial mole, and microscopically you will see many cystic spaces surrounded by the syncytial trophoblast and cytotrophoblast. So option B, diffuse proliferation of chorionic villi appearing as a mass of clear grape-like vesicles is the correct option. Now come to the next question. Following successful surgical evacuation of the uterus, what is the most critical component of this patient's long-term follow-up? After the complete evacuation, beta HCG monitoring is the most important step, and it will be monitored for up to 1 month in partial mole, for up to 6 months in cases of complete moles. So what is the chances of getting the so why we are monitoring the beta HCG level serially? Because the molar have pregnancy is a risk factor for the development of the gestational trophoblastic neoplasms like choriocarcinoma. So what is the risk of getting choriocarcinoma after complete mole? It is around 13 to 20% increased risk of getting getting the gestational trophoblastic neoplasm or choriocarcinoma after the complete mole, and it is approximately 0.5 to 5% increased risk of getting GTN after the partial mole. So this is very important to remember that the molar pregnancy increases the risk of getting the GTN, that is the gestational trophoblastic neoplasm, and we have to monitor the beta HCG levels just after the surgery, and continue to monitor weekly, and up to the 1 month, and then monthly after that. And in complete mole, initially for 6 months, we have monitored the beta HCG levels for the longer durations. So when we suspect that patient may get the choriocarcinoma or GTN, when the plateau after initial fall, the patient gets a plateau of beta HCG levels in the uh, four consecutive beta HCG monitoring every week, and if she gets a increase or rise in the beta hCG levels in the 3 consecutive beta hCG monitoring. So you have to be careful, be vigilant about the plateau or rise in the beta hCG level concentration, and then you uh, evaluate the patient for the presence of any gestational trophoblastic neoplasm. So option C, serial monitoring of quantitative beta hCG levels while on reliable contraception, because the pregnancy can also falsely increase the beta hCG. So patient should be on contraception during this monitoring. So option C is the correct option. So what are the take-home messages? Complete mole presence with the vaginal bleeding, hyperemesis, uterine size is more for the dates, preeclampsia may be seen before 20 weeks of gestation. On ultrasound, you will see the ichnostom appearance and absence of fetal parts. Genetically, you will see the 46XX entirely paternal DNA, and on staining with the P57, you will get the negative staining in cases of complete moles, because this staining is positive only when the maternal tissue or maternal genetic material is present. So if it is absent, then it is complete mole. If P57 nuclear staining is present, then it is suggestive of maternal genome, presence of maternal genome, and then it will favors the presence of partial mole. However, it will also be positive in cases of normal pregnancies. And how this genetic material comes? By the fertilization of an empty egg with a sperm which contains 23 eggs, and this undergo the duplication, leads to the 46XX chromosomal material, which is only of paternal origin, and and high beta hCG mimics TSH, causing clinical hyperthyroidism. Management includes suction curettage followed by 6 months of strict beta hCG monitoring and reliable contraception to watch for choriocarcinoma. So this is all for today. Thank you.